Welcome to Depression Prevention in the Workplace, what the research shows about interventions that work. This webinar is co-hosted with the Canadian Mental Health Association. We're glad you're joining us today. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be co-moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. We thank our program partners, Pain BC, Sport Chronic Pain Network, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You will be emailed the direct links for all of these items when they're available. We're happy to welcome our co-moderator for this webinar, Lawrence Blake, Manager of Workplace Mental Health for the Canadian Mental Health Association in Ontario, and I will let him introduce our presenter, Dr. JianLi Wang.
Thank you, Yusra. So welcome everyone, and welcome to our presenter, Dr. JianLi Wang. Dr. JianLi Wang is Professor of the School of Epidemiology and Public Health, Faculties of Medicine, University of Ottawa. He holds the position of Senior Scientist and Director, Work and Mental Health Research Unit of the Institute of Mental Health Research, affiliated with the University of Ottawa. Prior to joining U Ottawa in 2017, he was a professor of the Departments of Psychiatry and of Community Health Sciences, University of Calgary. Dr. Wang received his PhD in epidemiology at the University of Calgary. His research interests are in two areas: workplace mental health and risk prediction analytics. In the domain of workplace mental health, Dr. Wang is leading a national team project on early identification and prevention of major depression in male workers, funded by the Movember Foundation. This project is to develop and evaluate e-mental health programs to be used by male workers, which might reduce the risk of having major depression. In the risk prediction research funded by the Canadian Institutes of Health Research, Dr. Wang's team developed and validated the first sex-specific prediction algorithms for the risk of developing major depression in the general population. Presently, his team is conducting a national randomized controlled trial to examine the benefits and potential psychological harms associated with disclosing personalized depression risk information to users. Welcome, Dr. Wang, and thank you for joining us.
Well, thank you, Lawrence, for the kind introduction. And good afternoon, everyone, or good morning, depending on where you are. Well, as Lawrence just introduced, I'm leading the Work and Mental Health Research Unit at the Royal Institute of Mental Health Research, or MHR. The MHR is a research entity of the Royal Ottawa Healthcare Group and is affiliated with the University of Ottawa. Our goal, or the goal of this unit, is to conduct research to contribute to better workplace mental health and better productivity. And we seek to achieve this goal by producing scientific evidence by our members' own research and also pulling research evidence from different sources like the systematic reviews and meta-analyses to facilitate interdisciplinary dialogue and cross-sectoral dialogue, just like what we're doing today. And as a matter of fact, today's talk is primarily based on a systematic review and a meta-analysis we did recently. So it's just a few words about our research unit and institution. All right, to begin, Okay, so to begin, for today, I would like to first to have a brief overview about what I mean by major depression and how common it is in the general population to set the stage. Then I will introduce several categories of prevention strategies, and then I will move on to the systematic review and the meta-analysis on the randomized control trials on preventing workplace depression, from one of the categories of these prevention strategies. So, what is depression? Different people may have a different definition, and each definition will certainly lead to a different estimate of the prevalence of depression. So whenever I was at the meeting, when I ask people about how you think what's the prevalence of depression in the population, I always get a different estimate. Some said as 20%, say 10%, and even like 40 to 50%. So it's all depend on how you define depression. But for clinicians and the insurance companies, they have to use the same definition or the same diagnostic criteria for depression so they can communicate with each other. And the criteria used in the North America is described in the Diagnostic and Statistical Manual for Mental Disorders, or DSM. And you can see from here, this is a screenshot of the DSM, which outlines 9 depressive symptoms, including depressed mood or loss of interest in activities, changes in appetite or insomnia or hyperinsomnia, psychomotor agitation, retardation, fatigue, feelings of guilt or worthlessness, difficulties in thinking, concentrating, or making decisions, and suicidal ideation or suicidal attempts. So these are the 9 depressive symptoms. But if you have like a few or several of these symptoms, it doesn't mean you have clinical depression. Okay, to meet the diagnostic criteria for major depression, you have to have at least 5 of these symptoms, and one of them should be either depressed mood or loss of interest in activity. Okay, and the symptoms also need to reach certain levels of frequency and intensity, which means the symptoms should coexist for at least 2 weeks or longer, and most of the day and nearly every day. Okay, so you have to reach this kind of like intensity and duration in order to meet the diagnosis of major depression. And the third criteria is you have to have a significant functioning impairment. So the symptoms should have affected your interpersonal and social relationship and your study or your work in a significant way. Okay, so if someone have like 5 or more symptoms for over 2 weeks, sometimes it's really hard to imagine that she or he does not have any functioning environment. Okay, so this is the diagnostic criteria for major depressive episode, and how common it is in the general population. As I just mentioned at the beginning, and people may have different definition, and they have a different estimate of depression in the population. So what is the prevalence or annual prevalence of major depressive episode in the Canadian population? And according to the most recent Canadian National Mental Health Survey, which was conducted in 2012, the 12-month prevalence of major depressive episode was 5%, okay? Which means out of 100 people, Canadians, adult, age 15 and above, 5 of them are experiencing a major depressive episode. That is like the symptoms are consistent with what I just described, the diagnostic criteria. So if based on the DSM diagnostic criteria, the 12-month prevalence of major depressive episode in the Canadian general population was 5% each year. But that translated into like more than 1.3 million Canadians will have a major depressive episode each year. And women are more likely to have a major depressive episode compared to men. So the annual prevalence of major depressive episode was 5.8%, and in men was 3.6%. So, but the prevalence will be different, by different regions, by different populations. For example, in the United States, the 12-month prevalence of major depression was almost double than this number. Okay, and the prevalence also varied by sector, industrial sectors, and on the top is from the same data set. On the top of the list is accommodation and food services, which had a annual prevalence of major depressive episode of 6.65%. And second one was healthcare, social assistance. Third one is wholesale and retail trade. Number 4, information, culture, recreation. And number 5 is education, so teacher. Number 6 is public administration, the government people. So the prevalence of depression, vary by industrial sectors and vary by countries and regions. Okay. So major depression is prevalent and also disabling. Is a disabling mental health condition, and many of us, and also including the governments and the employers, recognize the importance of depression prevention. So what do we mean by prevention? So when we talk about prevention, many of us still have the misconception about what the prevention means. Some may think, think about, like, say, providing health services to those with a depression, but this is not right. Okay, according to the National Research Council and the Institute of Medicine of the United States, prevention means is an intervention that occurs before it's known who will develop a disorder and who will not. This means, like, say, for prevention, it only means that the intervention that happened, you used before you know this person has or do not have a mental disorder. Okay, so you may ask, what about the intervention that we provided when we gave it to those individuals who have an existing disorder, and that we call that as treatment. Okay, these are clinical treatment. They're not prevention strategies. Okay, so prevention, the National Research Council and the Institute of Medicine recommend that we save the term prevention only for the interventions that occur before it's known who develop a disorder and who will not. Okay, so there are many prevention strategies, but these prevention strategies can be classified into 3 broad categories. One is universal prevention, and selective prevention, and indicated prevention. So these are 3 broad categories, and we're gonna go through each of those. And for universal prevention, The universal prevention separates itself from the other two by the target population. Okay, so universal prevention are the interventions that target the general public or the whole population that has not been identified on the basis of individual risk. The interventions are directed to everyone in that group. So universal prevention, by this definition, the target population is the whole population or the whole group. So when you think you deliver the intervention or you intervene the whole workplace, the whole community, or the whole school, and this is, it doesn't matter, the population you targeted may already have the disease you're interested or may not. It doesn't matter. So you deliver this intervention to the whole group, the irrespective, the individuals in the group have developed or have not developed the health condition. Okay, so the target population for the universal prevention is the whole population or the whole group. Okay, I'll give you an example. So one of the example is, we say, the psychological health and safety standard in the workplace that was released by the Mental Health Commission of Canada. So this is the policy document which recommend the employers to establish a framework in the workplace to systematically monitoring workplace factors or risk hazards and to improve the work environment. So this kind of a policy intervention does not target specific individuals in the workplace, rather than instead this intervention targeted the whole population, within an organization. So this is one of the universal prevention strategy, and the other universal prevention strategy may include the organization policy, right? Such as, like, say, zero tolerance about this sexual or physical abuse or harassment, and the recommendations to promote positive mental health or health wellness. So this kind of policy are applied to the whole population within that organization. Or the organizational-wide programs, such as you set up the health and wellness program, and you encourage the employees to take physical activities during the break, and etc. Or the peer support group, and you target the whole workplace population. And for the policy or intervention outside of the mental health fields, like say seatbelt, right? We know, or the vaccination. This is all also the programs target for the whole population. You may not have the certain disease or infectious disease. You may never get a car accident, but you have to follow the rules and to use the seatbelt. And so in that way, we can reduce the car accident at the population level and reduce the mortality. So these are the interventions targeted the whole population rather than specific individuals. Okay. Okay, the second category is called a selective prevention. In these categories, the interventions target individuals or a population subgroup whose risk of developing a mental or substance abuse disorders is significantly higher than average, but prior to the diagnosis of disorder. So you can see the difference between this one and the universal prevention is the targeted population is different. And in this category of prevention, the targeted population are individuals or subgroup who are at higher risk. Their risk is higher than the average, but they don't have a mental disorder or don't have the diagnosis of a mental disorder. For example, if we know that women have a higher risk than men to have a depression. Youth are at a higher risk of having a depression, and people with a family history. So if your intervention targeted these subpopulation, and that will fall into the category of selective prevention. And sometimes the intervention may also target, based on not only the individual's demographics, but also a combination of demographics and the biological variable or status. And to identify the high-risk individual, as long as they do not have an ongoing or existing a mental disorder or depression. So one example from the heart disease is using the Framingham risk score for heart disease. I think many of you are familiar with the Framingham risk score, which is a statistical formula that include your the sex, age, family history of heart disease, diabetes, your blood pressure, your cholesterol level. So using the combination of these characteristics and to determine your individual or to estimate your individual risk of having a heart disease in the future. So you don't have a heart disease now, but this score to determine your future risk. And in mental health, one example is the Matter study we're doing with the support from the Movember Foundation, in which we identified high-risk men in the workplace using the multivariable risk predictive algorithms for depression, and we developed these sex-specific risk predictive algorithms using Canadian national data. So once we identify this the high-risk individual, and then we can provide the web-based cognitive behavioral therapy program, and also this is guided by coaches to foster the individual resilience and the self-care skill, so they can reduce the risk of having depression. So it's more like a proactive approach. And the third category of prevention strategies are the intervention called indicated prevention, which is targeting individuals at a high risk who have a minimal but detectable signs or symptoms of mental illness or substance abuse or problem, but also prior to the diagnosis of a disorder. So this type of prevention also targets individuals, but these individuals, even though they don't have an ongoing mental disorders, but they haven't shown some symptoms or the signs of mental disorders. So indicated prevention, that's until now, thus far, this is the most frequently used prevention strategy. And we found a number of prevention and intervention that falls in this category. And our goal today's talk, is to understand, the content of this intervention and the effectiveness of these the intervention strategies in the workplace. Okay, but to understand the effectiveness of each individual intervention, we have to use the specific design to evaluate the effectiveness. So how to evaluate the effectiveness is, I see many studies that use a pre-post kind of evaluation. You collect the data, baseline data, and you deliver the intervention, and then you do a post-intervention assessment, and you measure the change. Okay, but this kind of a pre-post evaluation has the lowest scientific rigor, because you're not sure whether or not any changes you measure are absolutely related to the intervention you implement, because you don't have a comparison group, and also you don't have the comparison group, even though sometimes you may have a comparison group, but because they're not a randomized group, and there's a lot of between group differences that may incur the biases to the results of the intervention. So the gold standard of the evaluation to evaluate the effectiveness of an intervention is called randomized control trial. So here, just a brief overview about the RCT, or randomized control trial. Is you first to select the target population, and you do baseline assessment, but you randomize the target population or participants into the intervention and the control group, and then you deliver the intervention. You do a post-intervention assessment, and for some trials, they also follow these the two groups into a longer time to assess the long-term effectiveness, and also do follow-up assessment. So this is just a brief overview about the RCT design, because the participants are randomized into the two groups. And so these theoretically, these two groups will be similar in terms of any measured or unmeasured variables. And that will make sure that any changes you observe are completely related to the intervention, and not something else. So what we're going to review today is 100% of the all the study we included are randomized control trials that are conducted in the workplace, in the working population. So we just completed a systematic review and meta-analysis on the effectiveness of indicated interventions for preventing workplace depression. So we select all the peer-reviewed study published between the January 2000 and September 2017, because I think the most recent, I think the first indicated prevention trial was conducted right after the January 2000. And we searched 6 the commonly used databases like PubMed, PsychoInfo, etc. And we have 2 research associates screened and reviewed articles, and they have the both associate could reach 95% of an agreement. We have a predefined inclusion and exclusion criteria, and we have registered the systematic review protocol in the Prospero. So all the criteria are predefined. So the inclusion criteria are we target the study must target the population, the employees aged 18 and over. They have the depressive symptoms, which has to be consistent with the indicated prevention definition. They have the depressive symptoms, but they should not have clinical depression. So they had to exclude the ongoing major depressive episode cases at the baseline. And then there have to be randomized control trials in the workplace or conducted in the working population. There must be a control group. The control group should be either like a care as usual, so-called care as usual in the workplaces, you receive nothing. Or the control group, the people in the control groups are in the waitlist control, which means during the intervention, they will not receive anything, but at the end of the trial, they're going to switch to the intervention. So they're going to receive whatever intervention received in the intervention group participants. And the outcomes that measured by this randomized control trial should be either depressive disorder or the symptoms assessed by validated instruments. And all the studies are published or written in English. So we have published this systematic review and meta-analysis in the American Journal of Preventive Medicine, published in this year, 2019. So if you're interested, and you can download the PDF from the journal website. Okay, so with the search term and the combination of the mesh term, we initially identified over 4,400 articles. And after the screening by titles and reading the full papers, and also assessing the risk of a bias, and at the end we have a 15 randomized controlled trials that are that met our eligibility criteria and were included in the systematic review. And for these 15 studies, the follow-up period are different, ranging from 4 weeks to 3 years. And the instruments used for measuring depressive symptoms are all validated, common, widely used scales or instruments for depression, such as the PHQ-9, the Hamilton Depression Anxiety, CSD, Beck Depression Inventory. So these are very commonly used scales for depression. And by looking at where these randomized controlled trials were conducted, at the top is the Netherlands. We found 9 randomized controlled trials conducted in the Netherlands. The European country have a long tradition in the in doing these occupational health and or mental health research. And second one is Japan. We found 4 studies from Japan, and 3 studies from the UK, 1 study from Australia, 1 study from Finland, and 1 RCT from the United States. So now we're gonna go over. We're gonna go through each randomized controlled trial to look at the where this study was conducted, and the targeted population, the context or the content of the intervention, and the results, and whether or not this works or in terms of reducing depressive symptoms. And our review found we can classify the intervention into the 2 categories. One is they are all indicated prevention strategy, but based on the content of their intervention, we can have we had a 10 randomized controlled trial that were designed, or the intervention were designed based on the cognitive behavioral therapy, or in combination with the problem-solving therapy. And 6 of them were delivered through the internet, and 2 delivered through the telephone, and 2 delivered in person. And we have a 5 study or interventions were designed not based on the CBT, but the education to enhance mental health literacy or exercise-based intervention, and 1 is acceptance and commitment therapy. So here is the first study, which was conducted in the United States, published in 2015. The target population were the employees, 167 employees recruited from the community. So they did not target a specific organization, rather than they recruited these employees from the community. So they can be from a diverse industrial sectors. And the intervention was the telephone-based CBT. Okay, the telephone-based CBT plus work coaching, assisted work modification, care coordinations, and the whole interventions consist of 8 sessions. Each sessions will last 15 minutes, and then the sessions were delivered twice each month by the master level EAP counselor. So these are the target population and the intervention. So how's the result? At the end, they found significant reduction in depressive symptoms in the in the intervention group in comparison to the control. And the second study was conducted in Japan, published in 2008. The participants were 118 employees from a large manufacturer company. The interventions included 8 sessions of telephone-based CBT provided by a therapist who is a master level, could be a master level psychology students or social worker or nurse. So there's 8 sessions telephone-based CBT. And the results show that after the post-treatment, there was a significant depressive symptoms reduction. The third one is also conducted in Japan, published in 2010. The participants involves 261 white-collar office workers from a metal manufacturer. And the interventions is slightly different from previous one. It involves one large group session, which lasted 3 hours, provided by a CBT specialist. And then after these large groups, there were 3 email sessions that was monitored or facilitated by occupational health staff of the company. And these 3 email sessions, they have like 7 to 10 days in between. The first session would be to review the CBT strategies that people learned in that big group, and then the rest of the session involves to apply these strategies or the skills you learned, and the participants need to complete the practices and also the homework assignments. And the occupational health staff will provide the comments on their homework or home assignments. The results shows at the post-intervention, there was a significant symptom reduction as well. The next one was conducted in the Netherlands. The participants were 139 employees from a large banking company, and the interventions 10 to 12 CBT or PST sessions facilitated by psychologists. And at the end of the intervention, the data showed that there was a significant symptom reduction as well. And the next one is also in the Netherlands. 239 employees recruited through the newspaper ads. And the intervention involves the emailed standardized CBT, targeting like a work-related stress through 7 phases. I assume that means 7 sessions. And that was monitored or guided by the doctoral level students of clinical psychology. And this one also saw a significant depressive symptom reduction. The other study was conducted in the UK, but the number of participants were relatively small. There's only 48 public sector employees. This one was built on the intervention was a computerized CBT at work called Beating the Blues. I think some of you may have heard this initiative, and this Beating the Blues program was loaded on the computer, and that was set up in a private room at their HR department. So the participants are free to use this private room on the computer, but there's no guidance was involved. But the end of the trial also saw the significant symptom reduction. Another study in 2014 in the Netherlands. Involved 231 from 6 companies from banking, education, security. The interventions were web-based CBT and PST. 6 weekly sessions. It's guided by coaches. The coaches are master level students in clinical psychology. But at the end of the intervention, the post treatment assessment show not effective in symptom reduction. So there's no meaningful differences between the intervention and the control group. Another trial published in 2016 by researchers from Japan involved 1,236 employees recruited from a web survey. And the intervention is these participants were provided access to the website which contains the information for depression, stress, psychoeducation information about CBT for depression. So, which is kind of similar to the website of many organizational website, providing information about the signs and risk factors and available treatment. So this kind of access to this kind of a website at the end of the trial, it shows the intervention is not effective in terms of symptom reduction. The other study was conducted in UK. The intervention was the mood gym. The mood gym, I think many of you know that mood gym is a well-known program developed in Australia, which is a self-guided program learning CBT and or the other psycho education information. It's a computerized CBT program which has 5 modules. You're expected to complete 1 module each hour. But this trial in the UK shows not effective in terms of symptoms reduction. Okay. Another one is Japan, conducted in Japan, with also involved a small sample size, employees from a precision machinery manufacturer. The interventions was a stress management program with the 2-hour lectures on work-related stress, behavioral and cognitive changes using CBT principle, and the lecture was provided by a psychiatrist. So it's like a typical stress management program. With the trial at the end, it also showed no effectiveness or the impact on symptom reduction. Okay, so these are what we did is not only to do the review or narrative review of the study, but we also conducted a meta-analysis which involved a quantitative component, which means we pull the effect size from each study and put them together and to calculate the pooled estimate of the effect size to give you an indication of the trends of the effectiveness. So you can see from here, which shows the effect size of each study as measured by the standard mean difference. Standard mean difference is the difference between the intervention control group at the post intervention and divided by the pooled standard error. And the pooled estimate is showed here at the bottom, which is a 0.44. Shows that when you pull the effect size together from different studies, it shows the CBT-based intervention is effective in terms of the symptoms reduction. And you can see from this graphic, we have a 10 randomized control trial. 4 of those, like this one, 4 of those, their 95% confidence interval overlapped with a null value. So, which means there, the difference you observed between the intervention and control group, maybe, there's no difference in between this group at the population level. But, when you look at the pooled estimate of the effect size, it shows the CBT-based intervention is effective. Now we look at the non-CBT based study, the one conducted in Australia, published in 2004, involved 73 casino employees. The intervention was the supervised aerobic and weight training exercise, physical activity, and behavioral modification. It's 20 minutes per day and 3 days per week. We're not sure about how long that one was last. But at the end of the trial, it shows this kind of intervention was not effective in terms of symptom reduction. The other one, the UK trial, also involved 90 employees from a large media organization. The intervention was acceptance and commitment therapy and innovation promotion program with the goal to enhance the ability to cope with work stress. And the whole intervention consists of like 3 half-day sessions of psychotherapy. But at the end of the trial, the data show that the intervention was not effective in terms of symptom reduction. And the Finland study has had a much larger sample of 718 from multiple organizations. And the interventions was 1 week resource building intervention, like a career management, a mental health workshop, role playing, etc. But the trial shows that this kind of intervention was not effective. And another Netherlands study with a very small sample of 30 white-collar employees, the interventions was 2 sessions of supervised exercise per week for 10 consecutive weeks. So 2 sessions, 2 times each week, and for 10 weeks. But the trial shows with the 30 participants shows a significant depressive symptoms reduction. And the 2008 Netherlands study had 218 employees recruited through the internet. The intervention was web-based self-help based on the problem-solving therapy for 4 weeks. And then a reminder email was sent to all the participants each week about the content and exercise. Trained psychology students offered feedback, working as a coaches to guide the intervention. And it shows at the end of the trial, the data showed significant symptom reduction. And we also look at pulled all the effect sizes together in the lower part of this graphic, and you can see we have 5 trials, and only like 2 show effectiveness, and the rest of the trial, their confidence intervals overlapped with the null value. But when you pull them together, because this effect size is so big, and the pooled estimate still shows effectiveness, show that the effect size was 0.4, which is statistically significant. Okay, to wrap up, I said, we're going to review that the prevention strategies that can be classified into 3 broad categories, like universal prevention, selective prevention, and indicated prevention. And we reviewed the prevention trial in the category of indicated prevention. And in this category, we found that both CBT-based and non-CBT-based interventions are effective, as shown by the meta-analysis, especially those the intervention delivered through the telephone, internet, or guided by the coaches, are effective. For the intervention, just focusing on the psychoeducation or self-help without any assistance or just a one-time education workshop, the effectiveness is not clear, because we only have one such a intervention. But overall, we found that the effect size is very moderate. It's only between 0.4 and 0.32. But because the internet and the telephone-based intervention are relatively cheaper compared to in-person intervention. So if this kind of intervention can be sustained, for example, all the intervention can be delivered through telephone or internet, it can make huge impact on the workplace mental health and the depression prevention. So even though these trials showed positive results, but they're still associated with a number of biases. First, we only have like 15 randomized control trials in this category. And also there are a number of biases. For example, when we look at the assessed biases across the study, we can see different type of biases exist in the study. In the many study we reviewed, the participants and the assessment were not blinded. So it is possible that the participants or the evaluator or the individual who collect the data, if they're not blinded to the group status, they could have provided data or answer that in favor of the investigator, leading to the bias toward make the findings too vulnerable to reporting bias. So the dark area shows the extent to which this type of biases exist, say blending of participants, personnel, blending the outcome assessment. So for the future trials, I think it's oh right. Also for in all the trials we reviewed, we found little information about the attrition, especially the uptake of the program and adherence to the intervention. So in the future, for the future trials, it's important to provide the information not only about the positive results, but also the uptake and adherence to the program, as well as the context in which the intervention is implemented. So the readers could determine the generalizability of the results. Also in the review, we found like a physical exercise appears to be effective in one trial, but we have no data. This study has provided no data about like I said, what is the minimum level of frequency and or the intensity that is needed to achieve the effectiveness. And finally, we have not found any trials on the modifiable factors such as like work stress, job demand, work-family imbalance, workplace social support, etc. The intervention to modify these areas, this kind of a trial, we have not found it. And we found no trials that measure changes in the employee productivity and return on investment. So all these trials focusing on symptom reduction, but not the job performance or return to work. And but such information I think is very important, because at the end of the day, the selection of specific prevention strategy will depend on not only the effectiveness but also the potential cost. So we need to do more research in that area. Okay, that's all I are going to talk, and now I'm open to questions.
So thank you very much, Dr. Wang. We do have a few questions here, and I'll read off a couple before we have to end, and then these questions will be answered and sent out after the webinar. So the first question is, of the 3 preventions that you have listed, which one was proven to be the most effective? Were there any follow-ups after the implementation of these interventions that you're aware of?
Okay. As far as to my knowledge, we did this review, systematic review on the indicated prevention strategy. And there's also a systematic review on the universal prevention strategy. Even though, there's in the area of universal prevention, there's a lot of also different type of intervention there. Some show effectiveness and some not, same like what we reviewed here. But as I just mentioned at the end of the day, which type of intervention you're going to choose will largely depend on, the cost, and not only based on the effectiveness, but also cost. But so far, we do not have any evidence in terms of the return on investment and the cost and benefit ratio. So now most of the study, I would say all the trials focusing on symptom reduction. So that's not, even though it generates some the knowledge and evidence, but we need some additional information to help employers or health professionals to determine which type of intervention we need to choose.
Perfect. Yeah. So the next question is, in your opinion, what are the barriers and facilitators in regards to the implementation of these interventions, as well as their successes?
Well, I would say there are many. One of the major barrier, I would say, is the collaboration between the employers and the researchers. I think the researchers may want to get into the workplace and to conduct any intervention trial, but it takes time. It takes time to build the trust and to build the relationship. And so sometimes the employer or organizations, they want to have something to be implemented immediately, but from the research perspective, it's going to take time to do the trial and to generate the data. So there's some kind of a mismatch between the organizations and the academia. So we need to have more communications, I think, to build the trust first in order to move the field forward.
Okay, our next question, and probably our last one, is, in your opinion, what are the uncovered grounds that currently exist in the field of depression prevention, and do you have any suggestions on how we can make further progress?
That's a good question. I think there's a lot of things that we can do, and so far, I think the most of the intervention trial were conducted in the category of the indicated prevention. There are also some trials in the universal prevention. There's less research in the selective prevention, which is, let's say, using multivariable risk predictive algorithms to identify high-risk individual, and then you deliver the tailored intervention to this group of high-risk individual. Like I just mentioned, that we have the potential intervention program for the high-risk individual or for those with the minimum symptoms. Some programs shows effectiveness, but we still, we really need the data about the cost and benefit, and to help us to understand which one is more viable, in compared to the other, and also different way, for selecting a selective intervention and indicated prevention, even though they all target specific subgroup of individual. Which approach may be more effective in terms of selecting like a high risk individual? This is we don't know, but in the other area of medicine, like in heart disease and cancer or oncology or diabetes, it is the common practice to use the multivariable risk predictive algorithm to estimate individual risk or their baseline risk in terms of the the likelihood of having a health condition in the future. But it's not it hasn't happened in the mental health field now, because we don't have many risk predictive algorithm in this for mental health problem. So our predictive algorithm we developed in the for depression, that's the I think that's the first one for the general population we developed using the Canadian national data, but we still have a lot of work to do.
Thank you so much, JianLi. So we'll end the Q&A session for now, but we still have 3 questions that will be posted online along with the recording and the slides. So JianLi, thank you so much for making the time to be with us and being so generous in sharing your knowledge and expertise on different types of public health strategies, as well as effective workplace interventions for preventing depression. And thank you, Lawrence, for your instrumental role as a moderator today. It is a true pleasure to have you both on air. To our audience, thank you for joining us. We truly appreciate your support.